and she will call to order. And I think Selena sent a sheet around with confirmation of board member attendance. Okay, so
Yeah.
shall we? I'll go through the names. Okay, Todd Graham,
Not voting.
Teresa King. Yeah, is that right?
Skin absent.
Yes, okay, Gail Marshall,
Yeah.
Brian Hinkle,
Voting.
Jamie Whitehead, Dwayne Holt,
Voting.
Robin Sue Capley,
Voting.
Marie Yarborough,
Voting.
Lily Simmons, not voting, Patrick Skate,
Voting.
John Bench,
Voting.
Susan Allen,
Voting.
John Eisenhower,
Voting.
Ingrid Kajmar is absent, excused, Jim Sawyer,
Not voting.
I am not voting, Jessica Bass, is not here, not attending, Carrie Hayes,
Here voting.
Roger Cinnamon,
Here, voting.
Eliza Bishop, voting. Jennifer Vanilla, is, absent, excused, I spoke to her earlier, Gary Burr. Okay. Oh, that's right, Gary had to leave early. Absent. Tom Reed. Darcy Throckmorton, Aaron Brown.
Voting.
I ran into Tammy earlier and she had a family emergency, so she is not attending. And that's it. We don't have anybody else from the outer islands. Okay. Okay, the voucher went around. Hopefully everyone signed it via DocuSign. I saw it go around earlier. So make sure you sign that. Public comment. Do we have any public comment tonight?
I'd like to ask a quick question, which I know you may not be able to answer, but I understand on the agenda tonight.
Can you say your name?
Sure. Mackenzie McElwain from Southwest Harbor. I understand on the agenda tonight is a COVID-19 update, and there's a couple of people here to give a presentation. And I would just like to ask permission if there's a question or two that I think of in the midst of that conversation. I'd like permission to ask a question or two during that conversation.
So usually when we have a presenter, the presenter is here to speak to the board. So we don't allow public participation.
Yep.
I mean, you can public comment, but we don't allow questions from the public at the meeting. You're welcome to submit your question, you know, for the next public comment if you would like to. But you know, the way that the board, it's like deliberation for the board and then the public can take comment.
So I can't ask any questions during that time.
That's correct.
Okay, thank
But
you.
you're welcome to submit your questions for a future public comment.
Okay, thanks.
Is there any other public comment? Okay. That brings us to approval of minutes from 13th September 2021 and our special meeting of 27th September 2021. Is there, well, are there any questions about the minutes? And if not, is there a motion regarding this? So moved.
Second.
Who's the second? Any discussion? Okay, all in favor? Any opposed? So we are lucky tonight to have Dr. Julius Trevin and Chrissy McGuire from the Mount Desert Island Hospital here to share some information about COVID-19 mitigation strategies and help us guide our discussion around the use of testing and vaccines and other COVID mitigation studies. So I think we will invite them to share their information, and then we'll have some question and answer from the board if that works.
Do you want a couple of chairs here? Would that be best? Or
We can pull up, yeah. I don't know. Can stand up. I actually would like a small table, but I can just use
Sure,
a chair. to
I'll
like-
get up on it for you.
Just because I have a bunch
Yep.
of papers, so I can.
I'll grab
sound
one.
intelligent.
It's been a long day. We might have lost our.
We're grateful for you for coming
Oh,
out on
thank
a late fall evening.
I am conscientious of one thing. I have my business card. I want to leave it for you.
Thank you very much.
So you can email any questions that you might have. We might not have the answers, but we'll do our best. to
I
get
appreciate
for you.
that. Thank you.
Okay. As soon as JR is ready, I'm Chrissy McGuire. I am the president and CEO of Mount Desert Island Hospital, our health centers. We take care of this community. We take pride in that. I want to give you a little bit of an update of what we've been focusing on for the past, I don't know, 29 months now. Taking care of and measuring the mitigation strategies and planning around COVID-19. So on March 13th, 2020, our very first COVID case was tested at MDI Hospital. It was cold rain Friday night. 13 is always my lucky number, so I consider that to still be lucky for us. We were able to begin our strategy on planning for COVID in our community. What we can tell you right now is this community has really taken a hold of our mitigation strategies, our communication efforts. The things that we have covering our faces right now is the #1 mitigation strategy that got us through COVID all last summer. We had from March 13th until October 17th, we tested at MDI Hospital 12 positive cases in that entire time frame. Just last week, we tested 12 positive cases. So we have seen an uptick, but last year we did a great job in mitigating that. We continue to partner with our community, with the school district, with the Jackson Laboratory, with all of our business partners on helping continue to mitigate and try to find, I don't know what our normal will ever look like, but we are deeply committed to making sure that we take care of our residents. What we are currently seeing right now, in July, in June, we had 6 positive. July, we have 3 positives. We also have 3.2 million visitors here. So we did a great job with that. Made sure that our businesses received over 60,000 masks so they could hand those out and they could make sure their front facing workers had those. We did surveillance testing. That's really important. The work we did with the school district last year with CIC Labs, making sure Jackson Laboratory did surveillance testing. The hospital did surveillance testing. What that prevalence testing does is provide a net, a safety net is there outbreaks, and if there are, how do we handle that? So we continue to do some of that testing. There is strains on our systems. There's huge strains on our supply systems, and there's huge strains on our ability to result test right now. So the state of Maine is not even letting us do asymptomatic prevalence testing right now. So we are primarily doing just symptomatic testing. The good news is if you look at MDI, we show up on a map as 99% vaccinated. So we have the highest vaccination compliance rate. Now, if you break that down, there are pockets that still we have areas of work to do to get the vaccine out to individuals. And we continue to do that work. We did over 12,000 doses and we continue to get those out today. We'll be doing our planning around the 5 to 11-year-olds. We are also doing planning for the booster. You've heard a great deal about that in the last couple of weeks regarding Pfizer, Moderna, and J&J as their boosters are coming out and going through the final FDA approval. In September, we had the highest positivity rate we've had since we started this. So we had on the island, these are small numbers. So when I talk to my peers, they're like, Chrissy, really? Yeah, that this is not bad. These are 35 positive cases. If we have one, we go crazy because we want to make sure that we have a bubble over MDI. We're protecting all of you and our kiddos to make sure they remain healthy, vibrant, and safe, and that they're able to participate in all the activities that you find people are trying to keep them in. So we look at contact tracing, we look at how to mitigate that, and we also are starting to stratify that by vaccinated and unvaccinated. And there's a significant amount of fully vaccinated people who are testing positive, either asymptomatically for COVID But the unique thing that Dr. Crevens will talk to you about is when you further slice that data, who's highest, most at risk, and who's seeing hospitalizations. Through, this data is a little bit old, it's a couple days old, so we have 15 positive cases through October on the island that we've tested. Now, mind you, that's what the hospital has tested. So we don't test everybody. Some people will go to the Southwest Harbor Clinic that Northern Light runs. They might go to Northern Light, or they might test at home. So we are only reporting what we know for tests in our community. The cases from last week were 6 positives. All 6 of those were from Hancock County. The majority of our positives are local zip codes. They are not from the out of state. We've had 2 or 3 out of state positives. So whatever those zip codes are, and it could be seasonal workers. We don't do that deeper dive, but that's what we're seeing for positivity. Now, of those 6 we saw, 4 were fully vaccinated and 2 were unvaccinated. No hospitalizations. That's the good news. That's the vaccine at work. There's no hospitalizations. Through the pandemic, we have tested 197 positives now through last week. And for this year, we have 149. So through all of 20, we had 50. So we know that there's an uptick. There's this little uptick right now for our community, but we also saw a plateauing. What we do is we do the planning and the care, and we're prepared to take care of those cases as we need to. The pressure now for COVID is at the major tertiary centers. Eastern Maine Medical Center, Maine Health, Maine General, Central Maine, and St. Mary's. So we keep patients that we can keep here locally, and we take care of them. So those ICU and critical care beds are open for those patients who need it. Right now, we saw over the weekend and increased again. So there are only 30 ICU beds in the state available, which puts pressure if you have a need for someone who doesn't have COVID to get them off of this island and to the right level of care. So that's the biggest challenge that we've seen right now. So for the planning that we want to ask, this is iterative. So if you have questions about what we're doing, what we're currently doing is just continuing to provide mass education, testing for symptomatic patients. We can't do the asymptomatic testing, and as I said, the state is not allowing that right now because of the backlog that they're experiencing. We also have subject matter experts such as Dr. Crevens, Dr. Julian Kufler, as well as infection preventionists who are available. We've got one right here. One of our head infection preventionists is at this table taking care of environmental control. So we plan with the Down East COVID Task Force. We do things such as how can we have Halloween? What can we do to make sure the kids are able to do things like that and continue to have socialization? So that's the work that we'll do. We'll continue to do community efforts. We'll continue to do what it takes to keep you all safe. And our next iteration of planning is all around the boosters that will be coming out. Any specific questions for me before I turn it over to the person who you're more interested in hearing from?
Don't say that. You're both very interesting.
So I think I know some of you know who I am. I'm J.R. Crevens. Been on MDI full-time 15 years plus, off and on 60 years roughly now. And I was U.S. Public Health Service Officer, retired Commission Corps. Came here after I retired from service in summer of 2006. I'm a internal medicine physician by training with some unusual experiences. I started my training I was a medical student in the spring of 1981 when the world changed. And then went from San Francisco, which is where I trained, to Western Alaska through the first outbreak of isoniazid-resistant tuberculosis in this country. And I took care of an RSV outbreak there where we had more children admitted to the hospital with their lungs full of snot. And we had children born that year. So I was under no illusions in January of last year when Everett from our ER called me and said, JR, have you heard about some weird virus in China? And I'm like, no, but I'll check it out. I'll call you back in 20 minutes. And 2 hours later, I called him back. And had a long discussion about it. 2 or 3 weeks later, I finally had enough on paper to write to Art Blank and Chris, and we started playing. I'm a numbers geek. I'm also a clinical doc. I'm also a very physical person. So I can approach this from many of those angles. There's also a huge amount of stuff, and I don't know what you already know. I'm sure you all know a lot and do this for the last year, seriously. I just want to say a couple things to clarify, a couple things that Chrissy said, and ask you, what do you want me to talk to you about? One thing I want to be really clear on is Maine runs a very tight hospital system. Yes, we have open ICU beds of certain types in this state, but they're mostly micro beds in little hospitals like ours. I was on last week. I couldn't get a bed for a critical patient who had his life hanging by a thread smaller than this pen. Not only in Maine or in Massachusetts. Fortunately, we found a bed by flying over Massachusetts. That's where the hospitals are now. This is just about don't drive on icy roads, condition for hospitals in this state if things don't turn around. So just as the background, the interesting thing is our numbers in Maine right now, our hospital admissions are near the highest they've been. We are still a little bit less than the average for the rest of the country right now. We are a tenth what it has been in some other states, but we don't have the surplus capacity. We also, in Maine, have made a choice not to kill people, as opposed to other states where they have chosen to have policies that have resulted in hundreds of thousands of unnecessary deaths. We chose not to do that. It's a great choice we made. Another number we should just mention, because Chrissy likes to talk about the 99% figure, which is greatly reflective of the incredible job that our pharmacy and our organizational teams have done, but it's not quite true. And she knows I'll like tag team run this. The way we calculate that number, they actually, I think we're up to about 106%. They don't let you be 106, they tell it, but it's also slightly a fake number. It's real important to understand that. The way that number is calculated is they take the number of vaccines delivered to people who gave an address in your zip code, and they compare that to the 2010 census of people who permanently resided in your zip code. So add to the 2010 numbers, everybody who's moved here in the last 10 years, minus the ones who moved away. Everybody who is working at a hotel, because we had outreaches to the hotels. Everybody who came in on a ship. I know that we're vaccinated people are coming in on ships because they meet with the people who go ashore, which, you know, it's good for them, it's good for us. A lot of summer residents got vaccinated here. We had the vaccine, they had the arm. They're part of our community. As an epidemiologist, they can spread it just fine. You know, so we have not vaccinated 99% of the people on this island. We have not vaccinated anybody under the age of 12. We have not vaccinated a percentage, we think about 25% or 30% of the people between the ages of 12 and 18. And we think we vaccinated about 90% roughly of the people over 18. We don't have a good way to gauge that exactly. In Maine, we have vaccinated 80% of the people over 18. That's calculated a little differently, and that's a pretty good number. I'm going to put that number up there just so we can sit for a minute on this whole huge issue of does the vaccine work? For every unvaccinated person, adult in Maine, there are 4 vaccinated people. So if you take a random group of people and I tell you they're truly random. If there are 7 vaccinated people, unvaccinated people in that group, then there should be 28 vaccinated people in that group. It's a random selection. There's 4 vaccinated adults for every unvaccinated adult. Interestingly, the vaccinated adults are more likely to be older and more likely to have pre-existing conditions. Nonetheless, if you look at who's hospitalized right now in Maine, they're about 2/3, average 2/3 to 3/4, depending on the week. They are unvaccinated. But they should be 4/5 vaccinated or more. So it does work. Is it perfect? No. And that's sort of where we get to these difficult questions. The vaccine is very good. It decreases your chance of getting it by 2/3. It decreases your chance of spreading it by more than 2/3. Because we know that vaccinated people who are infected, even if you test them and like, oh, look, you've got virus, the chance that they will spread it is clearly lower. Much lower. So, and it decreases the chance that you will get seriously ill. If you're a kid, it decreases the chance that you'll get heart problems, myocarditis, pericarditis. This is a big issue for teenagers. When they get COVID, they get a lot of heart problems afterwards, also that week, sometimes permanently. So we know it does those things, and we know it prevents death in non-zero, but it's not perfect. Which gets to why we're wearing masks. Right now, we're in a high transmission. So we need to be wearing masks inside because there is a chance that any of us, even vaccinated, could be low-grade contagious. And as a protective measure, we all wear them. The school has been real good about that, and it has some limitations. And that's where we are, and it's working. The big reason why there's two reasons why this year is much more than last year. One reason is Delta variant. It's more transmissible. It binds better to the ACE2 receptor. There's higher numbers in your upper airways, so you see big clouds of a really sticky virus. You're going to infect people. The other big reason is we've gotten up with the availability of vaccinations, and that's the good reason, and to a certain extent because people are just like, we got to get back to life. We are now socially interacting much more in ways that we did not do last year. That's good, but there's costs and risks to that we have to risk. There are so many things I could talk about. I guess I was told that the issues that there were questions about were what to do about vaccinations, what's upcoming, what should we do as a community. I am understanding that there are relatively no questions about masks, but if there's any questions about masks, I can talk about that. And then questions about testing and testing strategies, and most importantly, how to put that together. So what do people want to hear about at this point?
I think we could open it for questions, but I think also if you want to say, about anything about specific mitigation strategies and ways that we can increase, uptake in those mitigation strategies, like increase rates of vaccination and rates of testing and other things.
All right.
And then we'll open it.
Okay, so mitigation strategy. So what's happening with vaccines, real quickly, I guess this is important to cover this confusion. So Pfizer is approved, fully approved in adults, Moderna, J&J authorized. Moderna and J&J, Pfizer is now authorized for a booster. Now, just let's be real clear on boosters, because if there's anybody here who needs a third primary, they're overdue. So a third primary for people who are immunocompromised. You take high doses of certain medications. If you've had cancer recently, if you have underlying immune deficiency disorder, you should get 3 doses in your primary series. That's not a booster. We've been doing that for months. But it's important because there's some people waiting. They said, oh, I got Moderna, but you can't get a booster from Moderna. If you need a third primary, please call us and schedule. Boosters are now authorized for Pfizer. And it turns out that Pfizer waned a little faster. They've been testing that very, very, very regularly. Moderna has clearly waned less than Pfizer. Most of us got Moderna because they wouldn't give us big boxes of vaccine even though we asked for it. Moderna comes in a smaller box. I'm serious. That's why we got Moderna. Comes in boxes of 200 instead of boxes of 1,000. We told them we could use a box of 1,000.
Even in the freezer.
And Jack's offered to loan us the special -80 freezer. No problem. But no, so we all mostly got Moderna. Moderna clearly wanes protection a little slower, which is good. So as of last week, the first of 4 steps happened. You talk about this process being rushed. It's like, no, it's not rushed. So the first of the 4 steps, which was, there was a meeting where they took public comment and expert commentary and reviewed the data, and they agreed, yes, it's a good idea. That will then go to the FDA, the whole FDA, which will then do that, go through that data and ask any, put in any other comments and approve or disapprove. Typically, that's almost always a straightforward approval because this is an FDA committee. Then it goes to ASEP, which is a portion of CDC and outside people. That may sometimes, things sometimes stop or change there. That's happening next week. That's the Advisory Committee on Immunization Practices. And then it will go to the CDC directors. 4-step process, even for an emergency approval. There are ASIP may put in some caveats. They may interestingly say that J&J can be boosted with one of the vaccines, which would be, I think, a really cool thing. So if they allow that, I'd highly recommend it. If you had J&J boost with one of the mRNAs, it's the British thing, process. So that is going to happen over the next few weeks. The difference between the process with COVID vaccines and everything else is not that anything is done less, it's just shortened. Normally, it's like this gets you put on the agenda for, well, you guys are a committee, you know how that goes, and it goes from one committee to the next. The difference is that for this, the committee will meet next week and you will show up. So it will be considered. We don't know what's going to happen with that. There's also the authorization for younger age groups, which the data, and I'm seeing actually like things in the paper. You know, it's about to be approved, or it actually saw one that said it was approved, which is not true. So the 5 to 11-year-olds, the data has been submitted by Pfizer officially. It will be reviewed by the first committee on October 26th. Along with, there's been some data publicly released. We'll see much more data, presumably between the 26th and the 30th. And then that will then start that 4-step process. So people who think that they're going to have a vaccine the beginning of November, meaning like November 1st, it's like, no. We are already, what has happened, which is good, is we have already gotten directives both from the federal and state governments that said, if we were to authorize this, and we have vaccine in a different size dosing available for you, which has to be repackaged, think about how you would administer it, where you would administer it, how you would find the kids. So we should be thinking about those things, but we can't schedule that or make appointments. And we don't know for certain, crystal ball, I'm guessing somewhere between Thanksgiving and Christmas. And there may be surprises in the data. Till we see that data, we can't really say much. And we've seen only very limited. So we're waiting for the data on that. That'll be released heavily next week. Key mitigation strategy, ventilation and masks. A lot of people heard me ranting and raving about this a lot. This is an airborne disease more than a droplet disease. The difference is airborne means it hangs in the air in microparticles. That's why it's so key that people will be wearing masks to protect others. Once the particles get in the air, they float, 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 float. So if you're sharing indoor air with people, unless you have some incredible reason to either know that you are negative or you're all a part of the same family or cohort, like I have a close friend, we just sort of have to make the assumption within the group. You don't be spewing air. I'll be blunt, just to save anybody wondering how I feel. The concept that I should be able to walk around without a mask and breathe in a shared indoor space right now with high transmission makes less sense than saying that I should be able to walk into the building and take a crap on the floor. The difference is you can step around the crap and not get infected by it, but you can't step around that exhalation. So anyone who tells you that it's an infringement or it's not okay to wear a mask is just, that makes no sense medically. You can talk about it socially, but there is zero reality to that ethically, at least medically, ethically, the way I was trained to think medically. You are either contaminating the space or you're doing your best to not contaminate the space. So, now you know how I feel. What are the, so, questions on strategy?
And it isn't all open, gosh, everyone, but yes, what, so you, I think we have spoken a little bit at the hospital about some of your strategies for increasing vaccination rates there, and maybe if you mind just talking about how you.
I can talk about two different kinds of strategies. So our blunt brute force strategy at this point is you have to be vaccinated. We have a moral duty to provide an absolutely lowest risk environment to our patients. We swear an oath to put their needs over our own. And there is, so we are all going to be vaccinated. And that's not often, except for those few people who have medical reasons. It's extraordinarily rare. 1 or 2 out of 1,000 typically is the number you'd expect to see. It's not that high. So that's the standard for the hospital. That's not necessarily a community strategy. The bigger strategy we've had for the island is to answer questions, 50 people at a time like this, or 1 at a time, to understand what people's concerns are.
I think before our immunization, we call it an immunization requirement for healthcare workers. We have several immunizations we're required to have, but there were steps that we took before COVID was added to the immunization requirement, and it was town halls, it was individual meetings with subject matter experts, one-on-one, presenting data, having individuals who were terrified about this or who had heard about the myths around the vaccine or just even mitigation, even testing, that Dr. Crevens, Dr. Trevor Casey, Dr. Bob Miller, our other pharmacists spent hours and hours and hours counseling. And those intersections have proved positive for moving towards what we needed to get to. When we first started measuring our denominator of what our compliance rates were, we were in the mid-80s. We also have a retirement village, Birch Bay Retirement Village, who also has to be 100% vaccinated and is prior to the requirement. But we needed to start looking at that 13% and figuring out what that strategy was going to be about, and really just listening. And I think JR spent hours with people, talking to them. There are going to be individuals that you are not going to move off that roster, but there's going to be a significant amount who just need to have that one-on-one time with an expert to decompact and unpack all of that concern and feel more comfortable around the RNA and the Johnson & Johnson vaccine.
I just had a question. I've done quite a bit of reading, and I don't really understand the science behind. If I am vaccinated, but as a vaccinated person, how do I shed less virus than an unvaccinated?
So basically, the reason you'll shed less is that at the start of you inhaled at the wrong moment. Yeah, you went into a store where people weren't masked and you had to buy a left-handed who's what's it, and you inhaled at the wrong moment. The virus, drifted around on your mucosa until a spike protein found an ACE2 receptor, a cell surface receptor that's found on mucosa and in blood vessels, hopefully. And because you're vaccinated, it probably won't get into your blood vessels, but it might get into your mucosa. At that point, a race starts. The virus is trying to persuade your cells to make more viruses. And your body is going, I think I recognize that. Am I supposed to react to that? Oh yeah, I need to start making more antibodies. And so you'll start making antibodies. Now, because you've been vaccinated, you will make antibodies in days, not weeks. There is not vaccinated. It will take, even if it was a person who was unvaccinated, it will take weeks to develop antibodies. You will develop antibodies, lots of them, in days. When you start developing antibodies, they will bind to viruses and inactivate them. And here the term neutralizing antibody, which we've all read. What's a neutralizing antibody? It's just what it sounds like. When the military uses that military speak and says the target was neutralized. Yeah, you're out there neutralizing viruses in the same sense that a Stinger missile neutralizes a vehicle. However, just like that, you can still see that Jeep with the big hole in it after the Stinger missile hits it. If I do an mRNA swab on you, which we won't know, I will detect viral RNA, but it doesn't mean it's an intact virus. So what we know is that we can detect viral RNA in people who've been vaccinated. Well, first of all, 2 times out of 3, if you get enough virus that you are a third as likely, if you happen to breathe it in, as the person next to you who breathed in the same cloud if they're unvaccinated. But even if you do get it, if I test you for viral RNA, I'll get back plenty. But if I instead do a different kind of swab and culture it in a biosafety 3 lab, we don't culture lethal viruses normally. We don't do it here, don't worry, promise. I don't think there's a BSL 3 lab in Maine. Yeah, they have one in Connecticut that we send stuff to. But if I were to culture it in a BSL 3 lab, and this has been done, what we discover is that your viruses are really incompetent. They won't grow. And to quote a lot of Westerns, the only good virus is an incompetent virus.
So you are a mitigation strategy. Keep up the good work.
Is that so? Does that biology
Yeah,
make sense?
no, yeah.
Right.
Susan, did you have your hand up?
I did. I was just gonna ask, because I'm vaccinated. I understand and feel the ethical medical duties, but what are the, you talked about people with concerns. What are the, top 3 concerns? Just so we have it for the room.
The top
and
3
ourselves.
that we have heard, okay, and JL probably has a litany of them from our teams and from the greater community, all right, is it was rushed. Right. It was rushed to market, right? So that's the number 1 thing. I don't trust the science. And then in women of childbearing years, we have a great deal of individuals who are concerned about the impact on eggs and fertilization.
So answers to those. I always think of this one as really very interesting because it wasn't rushed. Someone who followed with awe how this was done. It was expedited. So the difference between rushed and expedited is if you want your expedited freight sent to California, you pay a lot of money because it goes from hand to hand to hand. And they make sure the next step is ready before the courier even gets in. Expedited freight, someone comes to your door, they take it to the airport, they give it to a courier who gets off the plane, who gives it to a guy on a motorcycle who takes it. I mean, that's really how it's sometimes done. If you've ever been in California traffic, you'll understand why he has a motorcycle and then a car. And that was how this was done. Every step, people were told, no, you can't take vacation. There were a lot of medicines that did not get approved last year because this was appropriately prior to. So it was expedited, not rushed. Answer to that one. There's actually the fertility one is very interesting because it has gone from like all new medicines, and it was not the first 100,000 people. They did not actively test it in pregnant women, but they included lots of young women. So it ended up being tested in the first group, about 1,000 pregnant women, because people got pregnant during the study. And it rapidly went from, gee, you can give it to pregnant women, to maybe it's a good idea to give it to pregnant women, to where pregnancy and desired fertility is now a specific indication, in the same way that heart disease is, immunosuppression, diabetes. Pregnancy or desired fertility is a specific special indication for vaccination, because COVID is, remember I said that the ACE2 receptor grows in blood vessels? The placenta is one big cluster of blood vessels. And it is a wonderful place for the virus to grow. And it results in either loss or poor growth of the fetus and death of the mother. There's this whole new social work thing of COVID orphans, which is this whole thing that because we're seeing. So that is a big issue. There's the people who, the mRNA technology, I think it's funny because people call it new. It's actually about 800 million years old. It's how your body does all its precision manufacturing. Your body wants to do some precision manufacturing of protein. It creates a short-lived messenger RNA. You translate that and create a protein. That's what messenger RNA is. It's something we make in our bodies every day, every second, whenever we want something precision manufactured. It rapidly degrades, so you don't keep making extra muscle cells. So I guess there's a bunch of teenage boys who love it, but probably there's a messenger RNA that's they could do that. That's not COVID. Anyhow, but the body rapidly degrades it. That's the limitation until recently on messenger RNA for vaccines, was how do you make them able to be stored and transported? And we figured out by using a combination of, it's like your baked goods, fat, sugar in a freezer, you can keep them, the mRNA from breaking down. It's fat, sugar in a freezer. So we figured out how to stabilize them. That's just so we can precision manufacture the protein. But it is new that we can do this, and that scares some people. The big things I'm hearing now, one of them that is a concern over myocarditis pericarditis, which is more common in young people, especially males. The interesting thing about that is that is clearly a very small number of people will have that as an immune response to the vaccine. And the reason is because that's an immune response to COVID. So while a small number will have self-limited cases, I think there's been one case in this country that had long-term sequelae out of millions of kids who've gotten the vaccine. However, wild-type COVID infection, wild-type means you got sick with it, as opposed to getting a vaccine. Wild-type COVID infection commonly causes severe heart problems, especially myocarditis pericarditis in teenagers. That's why when you hear about the kids who drop dead on the field after they have COVID, they go back to playing. Actually, it was one of the pros happened to us, I forget what it was, but I'll follow pro sports, but they made the big news last year. And the people have these very prolonged recovery lists and have no strength for months. Sometimes that's because of this myocarditis. And we're getting questions about that, and those are reasonable questions. If there was some way you could guarantee you wouldn't get COVID, if you were a 15-year-old boy and you were about to go to, McMurdo Station for 6 months, maybe wait till you're 16 to get it. But if you're not going to McMurdo Station, you're at much greater risk of it because you're going to get COVID. Right now, you're either going to get the vaccine or you're going to get COVID. And then the other real common objection we hear has to do with fetal tissue. And there's some reality around that. And there's also some bizarre confusion around that. The reality is the J&J vaccine, which is what's called a Trojan horse vaccine, meaning a shell that your body recognizes and accepts with something else different inside. Trojan horse. The shell of the Trojan horse is a harmless adenovirus that easily penetrates human cells. This particular, they grow the adenovirus and harvest the shell, get rid of the adenovirus insides and put the J&J vaccine inside that shell, which both protects it After all, it's a viral shell. It's designed to protect its contents, and it slips it into your cell. The way they grow that adenovirus shell is in, and it's not in HEK. I forget which one. There's a series of immortal cell lines, but they're called immortal. They're 40 to 50 years old. Interestingly, those common ones were developed in the Netherlands in the 70s and 80s. And these are fetal tissue cells where they took fetal tissue from an aborted fetus. I'm just straight about this. And they grew it in cell culture in the lab because very early fetal tissue from it will, if correctly handled, continue to grow. And these cell lines have been going on. They just grow them and harvest them, grow them and harvest them. And they're used in almost all research. And they can be used to produce very pure viruses because it's a human, especially things that only will grow in human tissue. And so the J&J vaccine, the shell doesn't contain fetal tissue. It is a grown in using nutrients, tissue that came from a single fetus that has been memorialized over the last 2 generations. There is no fetal tissue at all or product that comes from fetal tissue in the mRNA vaccines. However, they were tested in the development, some of the research to produce them and to make sure they were safe in a cell line called HEK. And there's different subtypes of HEK, which comes from different feeds. Also 50 plus, about 50 years ago. And this tissue has continued to be grown. And you can buy this tissue and use it. If someone came to me and said, Dr. Krebs, I don't want you to treat me with any medication that was tested on HEK, I would go, there's nothing I can treat you with. Because pretty much every single medication we use to varying degrees was developed or tested using HEK-based cells or sometimes a couple of other cell lines. Because that's the standard for how to do reproducible lab research for most of these things, because you can, for technical reasons, this cell line, because it's a proto cell line, you can put in certain factors in the broth and make it act like a liver cell. You could put other factors in the broth and make it act like an intestinal cell. So like ivermectin, to take an example of a medicine that has gotten a lot of discussion right now, because some people think it's beneficial and then some people get sick with it because they take too much. When we want to know what does ivermectin do to cell gut cells, that research was done on the HEK a decade ago, because we use ivermectin in people for treatment of gut infections. That's how you do the research. That is actually the biggest reason currently given by our current refusals. And it doesn't make sense to me because they want other medical things, but that's out there.
If we had 100% participation in pool testing, whether through voluntary or mandate, would we have a statistically significant benefit to all of us through that extra day?
So I'm actually, I'll pass that around. So let's ask. Anyhow, so in terms of, it says preparation for this is I got calls from various board members and administrators. So what would I recommend? So what do you think I should do? So I thought it through based on my science. And then I went back and I looked, and it turns out that the US CDC has sort of looked at all this and just updated it a few weeks ago for a strategy that looked at a combination of testing, risk mitigation, and vaccination. And these are their recommendations. And it's a great question. And these are their recommendations, which I think are really look a lot like what I said would make sense before, and then they're all right there. And it talks about, concentrating your testing. So there's pooled testing The difference, the only between pooled testing and other testing is convenience. So pooled testing basically means you take everybody like, we're a group, we all got a swab when we came into this room. They mix the virulent off those swabs all together and they test it. If it's negative, we're all clean, right? If it's positive, it's one or more of us. So the next day or 2 days later, you have to go back and test everybody in that pool individually. So basically, pool testing is a less intensive way in terms of resources to test individuals. Usually, that's how we're using it. There are places where they just do pool testing without retesting with the simple idea of what's going on in our community. And the way that's done most commonly is using sewage effluent, where if you have a dorm of students and there's no COVID-19 in the sewage effluent, no one in the building has COVID. You know, so that's another strategy that is used. But the role of testing is twofold. One is how much of an issue do we have in our community? Do we have to worry? So right now, we don't have to do that kind of testing because we know we have high community transmission. So we're in the red box right now, and we're probably going to be in the red box for several more weeks and months. And I doubt we'll get out of the orange and into the yellow for a couple months, and maybe we'll get down into the blue next year, but I don't know. That's one use, but the other use for pool testing is as a trigger for individual testing. And this is where you're going to get into some interesting questions as you look at the interaction between testing on this paper and what I would agree with for a recommendation and vaccination. And that is when you have activities that one are optional and two are higher or highest risk. Show choir. Kids in show choir. So I was thinking that. It's like, that's a great high risk activity. It's close together, it's exertional, and they're singing all at once. What could possibly go wrong? Wrestling, the weight room. Okay. You talk about layers of protection. One layer, last year's strategy, no sports. We don't really care about show choir anyway. That's not how we want to run our community. But you can look at both vaccination and you can look at testing focused perhaps in those groups. And it turns out that testing twice a week is much better than testing once a week. In most models and studies, you can drive what's called RE, which is the average number of people I infect if I'm infected, below 1. And if you drive RE below 1, you won't get an ongoing outbreak in the building. I might spread it to somebody, I might spread it to 2 people, but on the average, if that number is less than 1, outbreaks die out. And that's one of the ways we model is its testing strategy good. And it's a sort of a fancy mathematical way of looking at what happens in a community, but it all makes sense to you guys. If I test somebody once a week for something with an incubation period of 48 hours and a contagious period of a week, I might catch it before they infect somebody, I might not. But if I do it twice in a school week, the chance that they're going to infect somebody is much, much less. And so if you look at this model that the CDC put out in answer to your question, sir, it's highly recommended.
Well,
the
it's
question, of
highly
course,
recommended that you offer it. And the question for us is, well, potentially for us, is whether we mandate.
So actually, we were actually talking about this. I was pointing this out to Dr. Gasper. It helps if you speak government teas. So if you look, it says students. Offer screening to students who are not fully vaccinated at least once per week. Now that's offer. So this is, the federal government says balancing priorities as do you versus keeping kids in school, not forcing kids out of school. What are their? But then you go to high risk sports and activities and low risk sports. It says recommend.
Yeah.
Recommend is not the same as offer. If I offer you a cookie, you can take the cookie or not. Okay, recommend means the CDC is not talking to the students and staff. They're talking to you. They are recommending that you screen.
That we require.
Yeah,
Similar to the terminology of why we're in masks right now indoors. If you recall, it was, you may offer masks for indoors, and then we went to high risk, high transmission, and it was recommended that we have masks indoors.
so it's a hospital, when they recommend things to us, if we don't do what they recommend, we get closed.
So of the people who are now showing up positive, how much can you break that out in terms of how you think it's spreading within the community? Can you draw any, are you able to gather any information from what you're seeing?
I got one outbreak told to me today, that there were, that five or seven.
Seven altogether.
Yeah, five from that were all in the bar together, and it's now seven because some of them infected other people. That's pretty typical.
It's typical, and it hasn't changed, Dale, from where we saw the typical increases. And when JR talks about the upcoming, the holidays were havoc here, right? Like, so families got together, they ate, they were masked, and so restaurants are still an area, bars are still areas where we see transmission occurring.
Yeah, it's gatherings, and gatherings includes, going to a bar, includes going out. It's sometimes workplace. We've had less on this island than workplaces because most workplaces here are masked. For instance, when you hear about hospital outbreaks and a bunch of hospital units in the state have been closed the last year and a half, hospital outbreaks are actually almost never from patients. They are from staff interacting with each other with their masks off and inadequate ventilation. So it's social interaction, even at work for most places. Now, there's things like meatpacking houses, certain kinds of warehouses, et cetera, where people were observing and working shoulder to shoulder. That was different.
Well, we know that statewide, that the percentage of cases among the young, among people in the 20s, is quite significant, and it has been for a while now. So are you seeing something similar to that and how it breaks down by age in this community?
We're seeing actually younger. Yeah, the positives that we are seeing are family cohorts, and it's little kids.
And that's because as opposed to most of the state, which has a 80% average, which means in census, a lot of places were not like that, and we're honestly 90% of the locals are vaccinated. That means there's also areas in the state where 50 and 60% are vaccinated. But in our area, it's 90%. So most of the susceptibles are likely to be the youngest kids, but not entirely. And then of course, the other issue then is we do have, and this is where your question earlier about what happens if an unvaccinated person gets infected. Typically, they get a mild cold, something on the range of something between a mild cold and a medium case of the flu, which doesn't sound too bad. Unless you're 85 years old and already have heart disease or lung disease. And that's what kills 85 and 90-year-olds, is if they were going along okay and they might have been fine for 3 more years, and then they get the flu. And their flu case is no worse than the flu case of a younger person, but their ability to withstand it is zero. So that's sort of this other issue that we have to face. Is that the young, it can go. What we're often seeing is family will get it. It will go down into kids, it will spread sideways through kids, and you hope it doesn't go up from kids to grandparents.
When we talk about kids, we're talking, quite a few under 5. Yeah, have been exposed.
And in terms of risk, and it's one piece of paper I brought for myself in case people need to see it. It's this very interesting thing that kids between the ages of 0 and 4 are at moderate risk of getting severely ill. teenagers are at moderate risk of getting severely ill, not as high as adults. But the 5 to 11-year-olds are basically little vectors. They don't, that just seems to be the age where you react to it in such a way that you don't get very sick, but you also don't play havoc on your own immune system either. That's sort of the golden age. If you're going to get COVID, you want to be 7 years old. But then you also don't want to visit anybody who's either older or younger than you.
Right, keep them away from Nanny.
I have another transmission question of, you were saying about the droplet versus the aerosol. So if I'm outside
So,
and it's the, if it hangs in the air, isn't that kind of maybe
Yeah.
not so?
that's been looked at, and there's actually very specific recommendations that I'm painfully aware of, because I actually am involved in one of those situations where it becomes an issue. So outdoor transmission is very rare, and there's a couple reasons for that. One of which is there's a huge volume of air, much bigger than any building. The second is without a roof above you, each of us is a heat source, and our clouds tend to go upwards. And the third is that coronavirus is super sensitive to UV light. And there's actually some really cool new research coming soon to a shop near you where you can buy them, that there's a certain specific wavelength of light that doesn't penetrate even the skin of our eyes, but will plays havoc with coronavirus. And I suspect we're going to be seeing that in every classroom within a year or two. You might as well put it in your budget now.
Thanks, Chair.
Well, it's a special wavelength of UVC. You can't buy it yet this year, but pretty soon. But anyhow, all those play into outdoors. So the only time we've seen a lot of spread outdoors is when people are creating lots of droplets. So heavily exerting, shouting, screaming, and crowded very close together.
I like the football game that we all were at.
A football game is actually in the stadium. That is a little bit, it turns out they've looked at football games, not too bad. Football players, more so. It's also duration of contact as well. The reason I say I'm paying for the river, I'm on a rescue team, which means we are standing shoulder to shoulder, head to head like this over a stretcher, working as hard as we can for hours at a time. That'll do it. But unless you really are creating that indoor space, I spend very little time now worrying about outdoor. 3 feet apart outdoors talking, 6 or 8 feet apart outdoors singing. I have zero concerns about that. It's like so far down my list of things I worry about. Now, rugby, football is probably small risk. Now, different than football would be a rock concert. I mean, you get 4 people standing in the space of one, for every one person you have in a football stand, you can get 4 times that many people in the pit in front of a rock concert. That's where that's the kind of place they've seen it. Those essentially become indoor environments. There's no room for the air to breathe, move.
No mosh pitting.
That's paper.
A little earlier, you had presented that some other states or other places have had policies where they've let people die. I'm just curious what that was in reference to.
Well, they're basically, the science on this is really very clear. So for example, we know that universal masking prevents transmission. Choosing to discourage that is choosing to spread disease. We know that vaccination prevents the spread of disease and prevents people from getting sick themselves and spreading it to others. There are places that have done very little to encourage and in fact things to discourage vaccination. They are doing things. They're choosing to not do things that we know will save people. They're choosing to do things that will harm people. There are states which have said it is parental choice whether or not you should send your highly exposed child to school, that schools are not allowed to quarantine children even if they are known to be massively exposed, and they cannot require them to be tested. That's a choice. There are places that have refused to close high-risk businesses, even in times when cases were higher than this. There are states that have continued to do nothing when there were no ambulances left. Those are choices. You have to take responsibility to say what those choices mean.
Other questions? before we,
So, you referenced football as like a, I would say, low risk or even medium risk in your description of a football activity. And
here it's-
for clarity, I'm just trying to understand.
Yeah, they've
Here
got
is
it,
a
they've
high
got it,
risk.
they've got it there as high. And it's, I would say football outside with masks, I would consider it, you know, it is higher than most. It's one I wouldn't have a football game with unvaccinated people. I would think that's not a good idea. I certainly would test all of it. I would rule this as reasonable. Interestingly, football has not been, you know, in the data as high. I think that the football drills I worry about more than the game. I guess that's the other thing when we look at this is, interestingly, one of the things that they list as highest risk is weight room, which is sort of the interesting part. Where you have to really look at this question. And the football game itself certainly stands the team. It's higher risk, or it's not absolutely the highest. You know, it's I try to look at how I see it, and you're right. I think it is listed as one. Yeah, I was a wrestler. I know that I can sort of see that that is not a good idea.
And so I was just trying to understand as well, you said that we are in a high transmission, so we're red now. So MDIH would recommend that all high-risk activities be canceled or held virtually. Is that?
That's if we were to follow this, unless all participants are fully vaccinated. That's the caveat there.
And this is the CDC.
Right, and this is.
And I'm asking what MDIH is, like, because you guys are here presenting to us.
I would,
and
I
so-
would say this is a reasonable recommendation. There are some, it's, you know, part of it is how much you value these individual activities.
The risk
so-
reward proposition.
It is a risk and reward.
Absolutely.
Yeah.
And how much you consider them non-essential, you know. I will say just straight up front, I think that to exclude students from the core education right now for a vaccine that is authorized and not approved doesn't strike me as a good idea. I also think that right now, based on the demographics of who is not being allowed by their parents to get this vaccine, you might be excluding the kids who most need to be in school. On the other hand, for optional activities, that's, you know, more than, I think we sort of have to look at, you know, also interestingly, we play, you know, football. I guess I should mention, and that doesn't sound like a big difference, but it is. You look at an 8-man football team on the field and the way that's played, that's quite different than 11. That's a real thing. But, you know, these are judgment calls. It's interesting. They give you 4 sports and tell you to like label everything else based upon those 4 sports. You know,
Contact.
so it's golf, diving, football, and wrestling. Everything else sort of different sign based on the similarities does. You
I
know,
think what's interesting, Patrick, about this recommendation is the different use of the pool testing. Right, that if you're going to do the pool testing, you could do it on that specific demographic. And then you're reducing or eliminating the exposure of the greater pool from having to give up other activities. So that's one of the recommendations that's appealing to the CDC's perspective, is if you're looking at these high-risk pools and you're testing a high-risk pool, then you're not excluding the greater pool.
and it says that, you know, it allows people to participate, but, you know, it says we have a much higher level of scrutiny. And also, for example, you know, this is like I said, one page about everything you want to know, is it doesn't consider what they're saying is, what about band outside versus inside? Not in the budget. I looked through this footnotes. Do they consider the possibility that bands will play outside or singing outside?
For sure, and for clarity, I'm not suggesting
Right.
that we cancel or, high risk sports, I'm just asking your
No, it's,
opinion.
it's
I
an
think it
interesting
gives you
question.
more options than not.
Yeah, and,
Right.
and I don't know what, for example, what percentage of your, I know that we did some very, very, very specific outreach and advertising, including using some local personality who the kids who are into sports follow for the Pfizer vaccine during the summer. I actually don't know what percentage of the football team, might be, the football team may entirely be vaccinated, you know? In case you may be read, but it's still open.
Fair enough.
Yeah, so thank you very much for coming out and giving a lot of this information. I think this is incredibly helpful. And I think the task force itself has been incredibly helpful as well, right? So as a board, I think we've been utilizing that task force and we've had, members from the school there participating and hearing. And I know you're familiar probably with our mitigation strategies as we have them laid out right now.
Yeah.
Reasonably aware of what we're already doing. And I guess looking at this in particular, there are maybe some low hanging fruit that we're not doing that we could potentially do if we're using the CDC guidance and we wanted to go with that recommendation, such as, high risk sports. We're moving out of football season relatively soon and into basketball season, right? That's
Which is
probably a different kind of a risk.
Interestingly, I would consider that, of course, as you may notice, it's not on the paper.
It's right, but it's indoors. It's closer contact. It's exertion. It could be masked. Whatever. But I think what I would like to see is for this board to have a little bit more direct understanding of some of the kinds of things that they could be doing further to reduce that risk more, and then allow the board to have some ability to have a deeper discussion about those, like particular kinds of things. And so I guess I'd like to suggest that we work with either the task force or you specifically, maybe have the administration work on this, at looking at what we already have for mitigation strategies in place and where there are some particularly good things that we could potentially add, and have that reviewed and maybe come back with some recommendations for this board to consider moving forward as how we might change our current mitigation strategies and how we might add. So, some of this is, testing twice a week for some of these risk activities for extracurricular kinds of stuff versus once a week. Right now we're at once a week. Maybe we need to be looking at twice a week for testing. Maybe we need to be looking at, I don't know if a vaccine requirement is necessary for some of these extracurricular activities, but we're not only heading into the indoor sports, we're also heading into the season where families are going to want to get together, where we're going to have these holiday breaks, people are going to travel. And I think it would be helpful for the board to have maybe some a la carte stuff that can be done where it helps us understand each of these particular additional mitigation strategies, what kinds of impacts it might have for our risk going forward, and implementation capabilities for doing that. I think, we can do a lot of things. I don't think are necessarily on point, and you're not even recommending it, to have a vaccine requirement, but we certainly do want to have capacity to encourage people to get vaccinated. I think that's one of the ways in which you went about it at the hospital early on. You said that there were lots of outreach strategies that you employed. So if there are things that you've gleaned from that experience that you could bring here for us to understand as to how we can best communicate with our community to improve vaccination rates. Right now we have at the high school it's 75%, 25% that are unvaccinated. That's 127 students that are here that are not vaccinated that could be. And that's 127 more than I would like to see. And I think that many on the board would like to see. I would like to see those numbers change but I want to do it in a way that helps people understand what they're doing and why they would want to do that and what that risk mitigation is doing for them and for the community and for their schools. So that's,
One of the things first of all, I just need a point of clarification, because I'm not sure, in your pool testing, are you breaking it out by high-risk groups, such as the volleyball teams in the pool? No, it's
My
just
grade.
by grade, okay.
And
a portion of
then
the grade.
and one of the interesting questions I have about the full testing, I wonder if, and you may have this information, you may not. One of the interesting things we know is that if you see a person in a masks recommended area and they're not wearing a mask, they're probably unvaccinated. If you see a person in a place that says all unvaccinated persons must wear masks and they're wearing a mask, they're probably vaccinated. Because those behaviors sort, they're not independent variables. One of my questions is, what percentage of your vaccinated and unvaccinated is in your pooled testing? Do you know that information? If you are preferentially testing your vaccinated, that is not ideal. If you're preference, and I know that's not your preference, but if that's who it is, if you're preference, if you're randomly testing the whole group, that's useful. If you were, if your 220 or whatever students you were testing were all unvaccinated, that's great.
Just for the record, we do know that, our nurses know that, I do not know that, but our nurses know that data.
That data would be useful to know because it would give us some idea of how valuable that testing is right now. But what the biggest thing, and we meet, I'm glad to talk. I work very part-time now, and basically I live at the farm with a computer and a cell phone. That is answered pretty regularly. Is the key role that's different here than I've seen elsewhere is the concept that you concentrate your testing efforts, which we now know are limited in terms of what we can get done, on the persons at highest risk for transmission, which is the persons who are both in higher risk activities and are unvaccinated. If you could, it's worth doing test twice a week on those is much more valuable than testing a vaccinated student who comes to class in the morning, goes home in the afternoon, and doesn't do anything else. And they're not to be a big transmitter. The other thing I will say, having been a teenager quite a while ago, and but also working quite a bit with these groups in a variety of ways, even the most benign after-school activity, just that, unless it is completely supervised at all times by a staff member, is going to have a lot less masking behavior than the classroom. So just
right, so I mean, that's an example of something that we're not doing right now, which is requiring testing within any extracurricular activities.
Right, so that would
Which is
be-
something that could be
Yeah.
assessed and addressed, and then a recommendation.
right,
coming back.
it makes sense to me.
The other thing that we recommended is you have to start studying some benchmarks and achievement goals. Like, what do you want to get to? I would caution you, you're not going to get to 100%, but what do you want to achieve and how are you going to measure your success? And those are something that in order to say you quoted the number of 127 is what do we want to get to? We want to get to 50 unvaccinated. Is that success? So so you're measuring success. You feel like you're making some inroads in that number. I think you want to, as a board, decide what do we want to do? How do we want to? Want 10% effectiveness? We want to reach it through these categorical changes.
Eliza, and probably let see it. Probably go home for the evening.
It should just be a quick one, but I've noticed, I mean, something you just said about the sort of signifiers of like massive card, what you're, the connections you're making between places that are massive card and vaccinated behaviors. I think I'm also totally anecdotally seeing that maybe in opting into pool testing, families that are opting in are more likely to be vaccinated, which is kind of unfortunate. I think that basically what you're saying is it's sort of a bummer. That it's the same.
Compliant behavior leads to compliance.
We don't know. We can guess that might be true, but That's
Totally.
data we should have.
Completely. Right, yeah.
Blinded data.
Carrie and then we'll.
So I know at one point, this may be more a question for Mark than it is for you folks, but believe at the beginning of the year, we were talking about that we didn't necessarily have the testing materials if our numbers were to go up on pool testing. Has that changed? Or do we have it? Like if we were to require pool testing in order to do certain things at schools, as opposed to require vaccination, could we service that?
It's partly testing, people to do the testing. For it, you know, like,
No, it's a combination of both, actually. Right now, I can't tell you that there is any shortage or any stoppage, but that's at present levels, and we've not seen any problem with having our pools have the materials available and get the results back. But I can't tell you that if we increase those requirements, if we're going to have access to those materials, and I think we want the answer to that. And that is, I think Dr. Krevin said too, we're all subject to supply chains and all of those pieces. So if we double what our expectation is, we should know going into it before we do that. So I will do that research, but it's hard because, and I don't know, JR, if you can respond to that. I don't know, you and I were talking informally about that potential piece. The availability of, whether it's not just a PCR, but Finax and the pool testing resources, all of that in one envelope.
I mean, you know, interestingly, you're testing right now more than this. You're testing a different group. If you said we are going to only test unvaccinated students who are in extracurricular activities, I could be wrong, but I'm guessing, well, no, it's run the numbers. There's 120, even if every unvaccinated student is in an extracurricular activity, they're telling me there's 127.
Well,
That's
they're
two.
different for the K-8, or, yeah, they're on different for the K-8 students.
Yes.
Yeah.
Right.
I get
High
your
school.
concept.
High school. But that's 254 tests a week.
Right.
If we test them, if every single one was in an extracurricular activity, and we test them twice a week, it's 254 tests a week, which is about what you're doing right now on students. It's changing you're just changing who you're testing. I'm not saying you shouldn't test more, you could, but that's actually in terms of as I run the numbers, it sounds like the same number you're doing.
And we just, if people are wondering, we check with legal counsel and we will double check again, but extracurricular activities are not compulsory, they're voluntary. So the question about whether or not the board could do that, I think is pretty clear. It is within their purview.
And I will say something else. The group of students this will protect the most is the students who are unvaccinated and participating in those activities. The person who is going to get life-changing myocarditis or permanent neurologic dysfunction is the other wrestler who is not vaccinated, right? This is because if you have multiple unvaccinated persons in this group, and this is a high-risk activity or a higher risk activity, the person at greatest risk is the unvaccinated and uninfected person. Is it within your ethical requirements to maintain a safe school environment that you perhaps, how flip it around? If a parent came to you and said, my child needs a heart transplant, it says here, what would you say?
I'm prepared to make a motion. I don't think we need any more discussion or recommendations. Right here.
Yeah, then we should close out this report.
I know, I'm not saying I'm doing it, I'm
Yeah.
just saying. I will.
Are you implying that visit schools should be requiring something too?
That's an interesting question. That's a school system question. The visiting teams, I think, represent a lower but real risk. Like I said, I used to wrestle. I was exposed. If I was the top one in my weight group, which I usually wasn't, because I came from a school with 1,000 boys in every grade. If I was the top one in my weight group that week, then I got 4 minutes of exposure, or maybe 6 minutes. 6 minutes if I was lucky and did well to a visitor, as opposed to 2 hours 5 times a week to my teammates. Interestingly, they talk about the 15-minute rule. So, yeah, so visitor, you could argue that either way. You know, if you played rugby, a little more. But the reality is, you know, you get it from your family, you get it from your friends, you get it from your workmates. You could, I mean, it makes sense, but I'm not saying that would not be low hanging fruit to me.
Well, thank you for letting us come to your meeting tonight.
Thank you so much.
And just so folks know, Chrissy, JR, thank you, but this is not a one and done. I talked to these folks and the Down East Task Force, we meet at least every bi-weekly, so they're here tonight
I think
to
we have
support.
one
them.
more question.
Oh, I'm sorry.
Let Robin to ask a question.
Yeah, I didn't see your hand.
No, it's okay. I'm just, the kids who are getting it, are they having, what, are they having really bad reactions? Are we talking, I mean, are we talking?
You mean getting it meaning vaccine? or
No, the
getting it?
COVID.
So that is, so in, of course I can. So this is the COVID-19, I'll just give you this because I can print out another one. But right now, it's not a huge number. We probably had a couple of hospitalizations in Maine, and we, of course, we don't see it here. We would never.
Stay at our hospital.
Yeah, and I know of at least one case scenario of somebody who was pretty sick for a while, of a teenager, that I heard about anecdotally. So right now, nationally, we are seeing about, so 50 per 100,000, so about 1 in 2,000 kids has had a serious COVID infection in this country so far. Serious meaning bad enough to be in hospital. A lot of those end up life-changing. Kids get in the hospital, it's pretty bad. That may not sound like a lot, but there's it's about 40 million kids, 30 to 40 million kids, someone here probably doesn't know they're not in the 0 to 18 age range. So you can sort of run those numbers. That's, you know, hundreds of thousands of kids who've been quite sick. So it's worse, you know, on the same level of risk right now as say our vaccines.
And do we know how many of these kids are getting myocarditis from the vaccine?
That number is out there, and it's about, I think I could get you that number exactly. I want to pull out of my head. There's some nice articles comparing it. We know much more about that. That's what for the 12 to 18 than we do for the 5 to 11. That's one of the big questions with the 5 to 11, because it may be lower. We actually have not seen the myocarditis pericarditis much in the younger kids with the wild type infection.
And I know you say it's rare for these vaccine injuries or adverse reactions, but it's only rare until it happens to you and to your family.
This is the COVID-19. I think it's in the copy.
And so I guess I just would put that out there that, you know, it may be rare, but until it happens to you or your family, it's not considered rare.
Yeah, but that's also the same issue. The reality is we're called upon to make, you know, risk mitigation choices, because unfortunately COVID is, you know, putting, you know, thousands of people every day in
No,
the hospital. So, you know,
but
we're
is
in
it
that-
kids that are being
the
Right.
hospitals.
Right.
Is where I'm going. I'm not talking about adults, I'm talking about kids.
Right.
you know.
The risk of the vaccine is well understood. I need to, I get those numbers for you. So if you wanna. Email.
I can give it to you too, Jay. I can send it. in.
Let her write it. Let her write it.
It's fine.
Yeah.
Right on that, JR.
That is, yeah, that was the paper and paper. And that's just overall hospitalization. A lot of the, it doesn't, just the numbers of hospitalization. Which, as I say, is primarily just in the 0 to 4 and teenagers, the ones with most of them hospitalized. In this country. Actually,
The
international.
CDC data says that more than 500 children have so far lost their lives to COVID in the US. According to this.
Oh, yeah. Good. It's and I think, and the big thing that you read a lot about is a large number of kids have very, very prolonged signs of recovery, which is pretty tough for the kids.
Thank you, Jay.
Thank you so
Appreciate
much.
it.
Thank you.
Appreciate it.
So maybe we can just have a short discussion amongst ourselves, just because time is going on about our next steps, and then we'll move on to our reports and updates and kind of keep it moving, like say 10 minutes. Is that fair? Just because I'm concerned about the time. Maybe we don't need to have a discussion.
I'll start.
The plan, not here.
I mean, I feel like, first of all, what we were saying about extracurriculars and things like that are not mandatory. They're extras. I think that's a big thing to consider when you talk about any kind of a mandate. I don't know that we're at a vaccine mandate at this point, but I don't see a reason not to require pool testing. There's nothing about pool testing that's going to injure a person, a child. It's just gathering information so that all of us understand what the risks are and where we all stand in our schools. So, you know, if anybody has a good reason why we shouldn't make pool testing mandatory, I'd love to hear what it is.
Well, I think you gave us a good reason. We should target our pool testing. Be more efficient with our resources. Shouldn't just broad spectrum because we're not getting. So is the target
Mandated,
specifically
targeted.
for extracurricular activities because that's where the biggest concern is? Or do we need to target those who are not vaccinated and doing extracurricular activities? Or do we need to target XYZ? I think we need to maybe think about it.
Probably
Yeah.
happen is that we should have some sort of, ad hoc or something that works on this, because also, like at the high school, it would be fairly straightforward to say we have a requirement that unvaccinated students participate in pool testing. Like, because it's a very limited amount of people, and that we don't even have to break it down by extracurricular or whatever, because it's whatever. At the K-8, where we're very, like in K-6, no one is vaccinated, right? So then the population and numbers start, and extracurriculars are a bit different, whatever. So it starts a little bit different.
Like maybe pool testing for that age group looks like it does now.
Right.
And whereas for the vaccine eligible age group, it could be more targeted. I mean, that would be- that would be the only way to break it down. Yeah.
I guess the only thing with that is then who are you going to tell if we're trying to manage our resources, then who are you going to tell now you're not allowed to be pool tested? You know, if I say I want my child who's vaccinated to be pool tested, are we now going to have a lottery for which of those kids can be because of our limited resources?
I
So-
think this is probably a discussion that a smaller group we should have. I mean, also that it has access to the amount, because it's very possible that we could, say require that a certain group, but also voluntarily people who want it could also get it. Does that make, like, we may have that capacity,
Right.
Marie?
I think it's kind of, and I see Mark's jotting, so I think there's essential things that we need to have before even a small group can get together. One,
the information that Dr. Previns asked of Mark, which is the anonymous information about who's vaccinated, who's not. Two, the numbers from each, as you suggested, it's different. It's getting more complicated at the elementary school. So too is capacity at the elementary schools. They don't have the extra hands maybe that here they have at the high school. So it's getting that information out as well. I think in order for us to even move forward, we need to have some information about what those numbers look like and what the capacity is at each school, with each elementary school, which is vastly different from what it is here. Not, you know, I don't know if you've gotten your thing out for the nurse, the AOS nurse, but it seems as though that is going to be a critical piece to this. If we shift pool testing, if the decision after looking at the data is that pool testing is shifted, that's a huge thing. And it's going to require someone to be heading that up in a way that I know that the high school doesn't have capacity, and I'm quite certain that the elementary school has even less capacity. So I don't think we can do that without those chunks of information.
Brian and then Gail.
But I think a smaller group, and especially if you've got that extra information, a smaller group taking a look at this, where we have, you know, there's 500 students in the high school, and 75%, or let's see, 60% are in pool testing right now. You're requiring pool testing for extracurricular activities. You can shift some of that where you're not necessarily telling students or parents of students that their vaccinated kid is no longer in pool testing. Maybe it's just every other week. Maybe there's such a change in the way in which you approach this in order to maximize the effectiveness of your resources so that you're targeting as much as you can the unvaccinated kids and those that are opting into extracurricular activities, but you're still maintaining pool testing for the others to the best that your resources allow you to do that. If we have enough resources to do it all, and it isn't an extraordinary burden on the staff that we have, then allow them all in. But if you have to strike some balancing act, I think that we can do that and get a little bit more targeted towards the unvaccinated and a little more targeted towards the extracurricular, and still have testing available for all those that want to opt in, maybe just at a different rate.
I won't make a motion tonight because of what you guys are all saying, and it's very true that we have resources issues. But my daughter's best friend got COVID last week. She's okay. Well, what if she hadn't been? And she was in the hospital now. What would all your votes be? Right now, would you say we got to move for it now? Because that could happen tomorrow. So, my motion would have been to that we mandate pool testing for any unvaccinated students or staff in the high school to start with. But
And if
just
you
think
want to
on
make your motion, I think you should, Brian, but I mean,
sorry.
Sorry. But I'll meditate on that. Then Gail and then Patrick.
I just wanted to say that I think that either the small group or tasking the administration with taking the information we had today, working with Dr. Previns and others, and coming and looking for ways to fine tune this to be more effective, is something we should just let happen and not try to game it out here right now in terms of all the what ifs. They're all useful and they're all questions that have to be answered, but maybe that's more office work. And
so I'm just trying to understand the impact of, so now we're telling potentially vaccinated, like the whole sell on getting people into pool testing is that if you're in pool testing and you are close contact, you don't have to miss school.
But that's also true if you're vaccinated.
I'm sorry?
That's also true if you're vaccinated.
Okay,
For certain. Yeah.
fair enough. That's thank you.
So, what I would, again, it's not up to me, but what I would suggest at this juncture, if people think the small group is the right to go, is at some point move something like that forward. Because I think we could go around and around all night with our different conjectures, but we really need to get that information from Mark, and we need some people to take, either the administration or whoever it is, that sort of deeper dive into teasing out these issues.
I think another thing you need to add to that is as we're going into indoor sports seasons, like basketball season, do we need to require vaccination for parents and spectators who are coming into our gym? You know,
Right. So, yes, is there a person who wants to make a motion to direct the administration around to increase and refine our COVID mitigation strategy? That's how I would phrase it.
What you said.
Increase and refine our COVID mitigation strategies.
and so is that calling for a subcommittee? Or is that calling for the administration to handle it on their own?
That's
the
directing the administration, and what I imagine the administration will be doing is calling in board members. to assist with that process. Correct? Yes.
Absolutely. We're not gonna work in a vacuum. We have it. So we would welcome any participation of board members. We certainly, there's expertise within the task force that we pull in, our administrative team, our nurses. So yes, is the short answer.
Just given the critical timing of this, with the sports and the,
Mhm.
can we set a deadline that by next meeting, there will be some concrete things for us to either decide on or be reported?
Yes.
Two
so
that
I
have been
wanted
decided
to
on?
amend that motion to say that within by the next board meeting.
Or within 3 weeks, we'll have material to review and anticipate the board meeting before. Something, just so there's some concrete, because
Yeah,
that
a lot
motion
could
doesn't
happen in
substitute.
3 weeks. Yep,
right?
or 4 weeks.
Gail, do you
Oh,
want
it's
to
up to, as an amendment.
amend the motion?
I move that we task the administration with providing within 3 weeks a report for ways in which we can refine and improve our COVID mitigation strategies to be considered at the next AOS meeting.
We are, okay,
And I do comment.
okay. Okay, so that would be, oh, the meeting, yeah. Yeah.
Just want to make sure we're clear.
Oh, okay, because we're meeting in less than 4 weeks. That's the holiday, so, yeah.
Not saying.
Yeah, okay. So there was a second, any discussion? All in favor? All opposed? Okay. We did all that. So our next item is reports and updates. Starting with superintendent.
I'll be succinct because I know we have a lot ahead of us. Our enrollments are stable at 1,406 across the district, and we update that weekly. I feel really fortunate to be having Dr. Cravens and Chrissy here tonight, but we had the tip of the spear today. Dr. Naram Shaw briefed all main superintendents, and I'll just give a quick quote, and I agree. Dr. Shaw said this year seems to be even harder than the last. This work is difficult, demanding, and sometimes confusing. But public schools across Maine are doing an outstanding job for the kids in the state. As Dr. Crevin said, the 5 to 11 vaccination is forthcoming soon, and he described the process with the CDC, so I won't go into that. And again, the first clinics, the target would probably be somewhere towards Thanksgiving and between Christmas is what Dr. Shaw confirmed. Quick piece about the SOP, the standard operating procedure. what folks, I just want to emphasize, these are not our guidelines. These are not things that we develop locally. These are things from the CDC and the DOE that we follow. And I just want to emphasize the very, very hard, demanding, and continued work that our nurses are doing, our building administrators, and all of our staff, but particularly those two entities when it involves contact tracing. Very quickly, the goal of the SOP is to keep kids in school. That's the goal of the document. The second goal is to reduce new risk, and exposure at school is already factored in the SOP. And many people may not know that. The real risk is community impact, which is elevated versus the loose pods that are within our schools because of the mitigation strategies that we've done so far and will continue to do. I know it's been referenced, so I won't get into this. I'm pleased to take any questions, but I just want to thank the nurses and the administrators for updating this data. And our target point, even though we're very pleased with our numbers, our target point is to continue to work towards increasing those each and every day. I want to thank the hospital for their continued work on vaccinations, but we're also working with the hospital on flu shots and flu clinics. And I don't think any of us want to forget flu season is upon us, and we're talking about COVID, but we want to remember the importance of considering flu shots for young and old and our families. We're coming upon the holiday season. Travel guidance will be really important. And I'm just really proud of how our students and our communities have responded to the mitigation strategies, to working with us on the educational component. The vigilance and the mitigation is, I think, what's going to carry the day for us. So look for us to continue more public service announcements in that arena. I want to acknowledge the hiring challenge all of our principals and all of our schools are under right now, and it's not an MDI thing. Particularly, we have openings for ed tech positions, support staff are a real need. But it's very difficult because when people are either in a situation where they become ill or they become sick, it's a challenge to keep our schools running. And I just want to commend our teachers, our staff, and everybody for doing the job they're doing to keep schools open because it's not an easy task right now. I would encourage anybody that may be considering these support positions to reach out to our principals. We are considering job fairs. We're considering all kinds of platforms that we can use to recruit because we're in the same boat as everybody across the county, across the state, and across all industries. And that is, we are in the midst of a hiring challenge. Quickly, in response to Marie's question, I have posted the floating nurse position. We're doing everything we can to advertise, to recruit. Nurses are particularly hard to find right now. And we know that's a key element in supporting our SOP and keeping our schools open. Budget planning is underway. Matt mentioned that. And so building principals are meeting with Nancy, and that process has already begun for FY23. We have updated our MBI RSS website. If you go to it, you'll see it's a newer version, but that is a temporary version until the full platform comes online soon. And I lastly want to give a huge shout out to our nurses, our administrators, our staff, and our students, because this is arduous, relentless work, but I couldn't be prouder. They're doing a great job. And I'll close by saying, on all sides of the aisle, it's really tough right now for everyone, for families, for students, and what really carries the day, whether we agree or disagree, is kindness and empathy, and really appreciate that. Thank you.
Any questions for us? If not, we have updates from Directors of Education, Rhonda and Julie.
I'm going to start us off. There in the agenda, there's a link
to our update. But at the beginning of every year, for a long time, part of the professional growth and evaluation cycle is for teachers and schools to set goals. And so on at the beginning of every year, the schools within each building, the staff get together and they discuss what they want to work on. And most of our schools are choosing to look at classroom and school culture. And then individually, teachers also set goals, and they choose those goals from the 10 elements which we follow as our professional growth evaluation cycle. So the top pieces or the top things that people are focusing on are content, classroom strategies, facilitating conversations, and making connections. That's making connections within content, not connecting. The ways that teachers are looking at accomplishing those goals really fall under two categories. There's the collaboration piece where they want to get out and they want to watch other people teaching and then debrief with them. They want people coming into their classrooms and having that debrief. They also want to work with our instructional coach to help with planning and with co-teaching. Then there's another set of strategies to get at these goals where people really want to dive in and look at data. And they want to use that data to inform their instruction. So doing things like looking at student work together with colleagues and then making some decisions about what, or just having discussions about, Julie and I are both looking at student work together, and Julie's kids did way better than my kids, and she can help me with my instructional strategies to improve my practice, having those discussions. Having cross-disciplinary units that they're working on together and then looking at how kids are doing on those and improving teaching practice that way. So those are just some of the goals and the ways that teachers are trying to get at their goals, trying to work on their goals. And the one thing that we keep bumping up against a little bit is time for teachers to work together on these things, because collaboration and looking at data take time. On the first page of our little newsletter here, one of the pieces of our data is our NWEA, and we are in the midst of the fall testing window. It goes up until October 29th. And so then in November, teachers will be taking that data and looking at it. One of the nice things about the NWEA in recent years is that they really made it very individualized to students, and the math and the reading and the language arts piece or language usage piece is broken down into very distinct skills and ideas. And so if I am a student and I get a RIT score of 200, the teacher can go in to the NWEA site and see what skills and strategies should I be developing and really working on. Which ones should I get introduced to, and which ones should be reinforced for me? Which ones have I already know, but I could use some more work on. And so that helps us with moving on to my last piece, response to intervention. The interventions that I provide as a teacher or we provide as a school can really be targeted, whether that's I need more help with something or I need enrichment in an area.
Okay, I'm just gonna draw your attention to some hyperlinks that were actually in this document. It's not a Google Doc, so it wasn't necessarily blue, and if you opened this, you may not have clicked on this. So in August, I presented a response to some of the requests put forward by the Anti-Racism Task Force, one of which was to train all faculty in a required training, and this is the kind of a look under the hood of the training. So we had 284 staff members participate in a Coaching for Equity workshop. And our objectives here, if you can kind of scroll through it, you'll see all the outcomes. So there were 5 key outcomes. You can't see it, I'll blow it up here. Quick. See that? To develop strategies for talking about race, power, and systems of oppression, to develop strategies which lead to changes in teachers' practice, to identify what equity is and what it should look like in your school, raise awareness for issues of inequity, explore how to recognize and prevent inequities in the classroom and school communities, and to receive tools to empower the change-making that contributes to an equitable environment. That was our kickoff to the school year. As I mentioned earlier, 284 participated. That included administrative assistants, that included kitchen staff, that included, ed techs, and teachers and administration and maintenance. So we have some additional offerings that have been listed in that newsletter. These are sort of the hot books that we're working with this year in different teams. I'm going to pass these around for your perusal. I actually have extras of the Coaching for Equity book. If you're interested, walk down in the office with me after this. I'm happy to share them with you. So the last piece I want to talk about is, and again, this document is hyperlinked in the curriculum audit section that's underlined. We are starting curriculum audits. That's another item I was asked to begin working on, and we have begun to use this rubric, which comes from the training we all experience. And we're just looking at current offerings we're practicing and seeing whether or not it's a fire hose response or if it's an architectural response to building equity. So we, for instance, we have a bullying program that we do every year in the 7th grade. And we decided to take a look at it and see whether or not it was meeting the components of really building a relationship and culture within our school communities that supported equity. And we evaluated and said, well, it's a good program, but it is a fire hose response. What are the things we need to do to really build something more systemic? So we are starting to use this in our team meetings. It's just starting and it will grow, but I did want everybody to know the tool we are using to look at items. So I would invite you to take a look at it when you're, not now. And then there's another hyperlink to of some work we're doing with curriculum audits by Sando Associates. You can take a look at the profile of that person at the bottom of that handout. Oh, and it's under updates. I did want everybody to know that I've been in regular contact with Sarohi. She's one of our student leaders and participants on the Anti-Racism Task Force. She's a senior now. She did keep me abreast that they were hoping to have their group formed by this week, but they realized there was some communication breakdown in terms of getting the information out to people to apply. So they've extended it and hopefully next week they'll be organized and moving that group forward. And so we'll have more to report later. Are there questions for Rhonda or Julie? I don't see anyone. If I can't always see everyone, so if someone sees someone's hand up.
Okay, that brings us to subcommittee updates, and we've just done the anti-racism committee. we've done that, so. Superintendent search committee, we, I think the listening sessions are underway. I hope, I know I talked to the teacher today who was doing one, so I know. Anyway, those are happening, and we'll hopefully have more information about the survey results tomorrow when we meet with our team. And we'll have probably more to report at our next meeting after these listening and survey is done. I would say. That sounds accurate. First of that committee. Okay, middle school.
Yes, we've met twice. They were fruitful meetings. We have more to meet and talk about. There's nothing really to give you any specifics right now, but we're plotting through, powering through the sort of the 4 objectives and the 4 issues that we're trying to figure out. So more to come.
Todd, are you handling restructuring?
I am. Yep, we did meet once, and we are looking for new leadership in that subcommittee, so I think we will back to you just to do this. That's where we are with that.
So, because the hour is late and, I think what we should do is put that, the reorganization of the, reorganization committee should go on our agenda. We should add as an agenda item for next, time, because I know there are potentially some people that's just, in the, does that sound right? to you?
They just haven't surfaced yet, and it's just needs to, I think, come back.
Yeah,
here,
so we'll put that on the agenda for the next, meeting. Okay, toward anti-racism. Our next, discussion item is about, the board commitment to equity and excellence, which is something, which is a document that Christie had originally drafted and had gone around, for people to review, and I guess it's a discussion item, so we're not gonna be like, voting or taking any action about it tonight. But, hopefully, since people have read it by now, since it's been on the agenda several times, we haven't got to it yet until tonight. If there are questions about it or comments about it, maybe this would be a good opportunity, to share them, and then we hopefully have this as an action item on our future agenda. I assume everyone was able to access the link in the. Yes, if there are questions or comments about the statement, which was drafted mostly by Christie with some input from others, but yeah, fire away. Or maybe just move down through this. Because, it's executive session. Also, if you have questions or thoughts about this that you want to email to me for the next meeting, I will also take them in that format. Okay. Moving on. For our action items, we have our first one is computer device lease agreement. I think Josh or
Yeah, so Josh is prepared to answer any questions, but this is one where I messed up. I didn't catch. It's not a financial mishap. What was presented to the board was in the last minutes. You authorized an expenditure, 2 expenditures actually, $238,330.50 for the K-8 schools to authorize a 4-year lease for 21 to 25 for computer devices. You also authorized the Mount Desert Island High School leases not to exceed $639,275. No problem with the high school piece. The problem is that the actual amount is $278,330.50. So what happened was, when the agenda was released, it did not have the correct amount. And so there have been no funds that have been over expended. We are budgeted for the appropriate amount, but it was an error on my part not to have the motion be 278, 330. Josh, correct me if I'm wrong, we signed the contract, I signed the contract for what the board authorized to date, nothing to exceed that. And the company is holding, so if the board does approve this, we're
Right.
okay. We have there's no additional funds being requested or within
Right.
those parameters, is that
Right,
correct?
the expended, right, it's not gonna cost any more for this year, because those payments have already been made. And that was for the first year's payment, so this is for the total amount of the lease over the 4 years.
So this motion is basically to correct the error that I did not put forward for the total of 278,000. You approved 238,000.
Marie?
I make a motion to authorize the 4-year lease from 2021 to 2025 for MLTI devices for all MDI, RSS, AOS, K91, K8 schools except Frenchboro, not to exceed $278,330.50.
Second.
Any discussion?
Does this need to indicate that it's, sending the prior action?
Selena, I mean, I don't think that would be, well, hang on a second. Josh, we signed the contract for the 240.
Yeah, we signed it, so a new form's gonna have to be signed for the 270.
But what this motion is allowing them to do is to have their superintendent act to approve an amount not to exceed 278. There isn't a new contract coming.
No, it's just to correct that number.
I think we could just note that. in there.
Yes. So it won't happen, there will not be a new contract.
Any discussion? Oh, that was, any other discussion? Okay, all in favor? All opposed?
Thank you.
Approval of administrative review, Mark?
This is an annual, it's required by the state that the board approve the review of the plan. And that is in fact what's before you. You're not approving the plan. You are approving that the administration has reviewed it. That process included me sitting down, reviewing the emergency plan. And if any board member would like to sit and has questions, would like to go through that, I'd be happy to walk you through that. I sat with Ian Braun, who has worked with our developing our plans across the district. I also spoke with Jim Willis, so we have completed that process or the review of the process. And there are minor edits that we're in the process of finalizing, and we will distribute those updated plans to the schools.
I move we approve the administrative review of consolidated MDIRS AOS 91 versus.
Second.
Any discussion? Okay, all in favor? All opposed?
Just with your permission, I'd like to defer to Rhonda on the next piece for the questions, because she facilitated that meeting.
Yes.
Thank you.
Can I say something? So, people might remember that we had had the second reading of this public participation board meeting at a prior meeting. And there, we felt like we needed to go back, it needed to go back for some revisions. So it did go back and we discussed it at the policy committee meeting that Rhonda so ably facilitated. And we, essentially, people hopefully have clicked on the links, but we chose not to add, like, we've never had a requirement that you needed, that there was priority for residents of the local unit in public comment, and we, in our updated policy, continue to not. So, because there was, for people board, newer board members, there was concern that if we both limited the time and limited the, sort of limited public comment to, or prioritized local residents, that there could be a scenario where we would be attempting to exclude, say, a teacher who, taught at Fremont but lived in Illinois. And so, and that's not our intention. We value public comment. And so, as the policy committee and based on, Todd and other people's sort of comments, we chose to recommend the language that appears in this. That sounds right. So let's come back to you on this. Why don't we take them separately? That right? Is there is there discussion of this? Are we ready to move forward on this public comment policy?
I just have a tiny nitpicky thing. It
Yes.
says that they have to state their address, which like 109, don't we really mean town, or do we really want people to state their address?
I don't think they need to state their address.
So it says address, so can we approve it by just striking town? Because we typically ask people to say, what town do you live in, or what community do you represent?
Yes, I think that's.
The only hesitation I have is the legal reference, and typically, and I agree with you, Marie, typically people are asked to state where they live there as their town. We've never required, or Selena, we've never recorded an address.
No, which is,
So not to hold up the works, but we can check with legal counsel. But the board chair, when they're recognizing individuals, I believe when they're asking them to state which community they're from would be sufficient and for an address requirement. But I would want to be careful with anything referenced in statute.
I don't think a statute requires people to call it on it and say their address. I'm sure we can say name of town. I
Sure.
feel.
I just want to double check, because we've been very particular about the wording on this,
Right.
about everything, but it says address, which is not town, which is what we do. So,
I'll double check on that, but I'm comfortable going forward with name of town. If someone wants to make a motion on that.
I motion that we strike address, replace it with town.
I mean, on the whole, to accept this review.
It doesn't matter, the edit doesn't matter.
With
the edit.
Yeah, right.
Okay, I move that we accept revisions of policy with the recommended edit.
Yes, the policy on public participation.
The policy on public participation at board meetings.
Who's the second?
Mary.
Okay. Any discussion? All in favor? Any opposed? Now, Rhonda, do you want to explain the physical restraint?
So there's a new law that begins today that changes the definition of what physical restraint is in schools or what seclusion means in schools. And so they really narrowed down what those two pieces mean. And in the past, we've restrained kids if it has to do with safety, their safety or someone else's safety. And this changing the policy isn't going to change how we approach working with kids. We're still going to love them. We're still going to take care of them. You will see an increase in the number of reports because of that expanding view of what restraint and seclusion. So a couple of examples are like in the past, we have a couple of schools that have pre-Ks, and 4-year-olds are not so always willing to walk into the building on their own. So, you know, I'm bringing my child and they're having a grumpy morning and Julie's their teacher and I'm holding my child and I pass my child off to Julie and she holds him just like I was holding him and is comforting him and walks him into the building. Under the new law, that's a restraint and paperwork has to be filled out. So that's, you know, like an extreme example, but the point is it's new law. We have to have these two policy changes. There's the policy itself and then there's procedure policy. But know that the kids in front of us aren't going to be different. The training and what the staff are doing isn't going to be any different. It's just, you're going to see more reports.
Why, who thought this was a good idea? I mean, it's like we're talking about overwork, everybody being.
Well, I think it was a response to some high profile cases of actual seclusion and restraints.
Yeah.
I guess I'm
There
just going
was,
by your example, it just seems weird.
Right, there were a couple of, I don't know for sure, but a couple of parents that had bad experiences with their children at school and that went to the legislature.
Yeah.
Probably the pendulum was going back the other way after a couple of years, because, you know, 3 or 4 years, because people will see the ludicrousness of it, but for right now, this is what we have. Was anything
Thumbs up. Are there other questions or does someone want to?
So this in essence is aligning the state statute.
right?
Are you moving? Yes, okay.
I know.
Second do it.
Second, agree with that, Marie? Any discussion?
This is the first reading. So we actually
We made a decision, I believe, as the policy committee to bring this for bring it for first and final because it goes, the law goes into effect
Yes.
today, so we have to align our policy. Sorry, I should have explained that before.
So
And I could,
can
we can
I
do these as
have
a
that
slate. I
have them
think.
as a slate, the
Yes.
procedures and the policy.
May I ask a question? And Susan, this is, so it's first and final reading.
Yes.
Thank you.
I should check that, the agenda. which is the first and final.
Marie, do you adjust your second to use it as a slate?
Second slate.
Okay, any discussion? All in favor? All, any opposed? Okay. Is there other business? Future agenda items, we know that we have a report from this public mitigation strategies. And we will have a continued policy review in our, and those will be first. Reading. And I know we'll have the workplace bullying as a first meeting.
Reorganization of the reorganization.
Yes, reorganization of the reorganization committee. God, sorry, behind the law.
I don't know where this is, but I think we need to, it needs to be on the agenda somewhere, the policy review on virtual meetings and voting
Yes. that's another
and
one that's in
making public comment. If things go virtual again, public comment available during those virtual meetings. So I don't know where we are with that, but I want
That's
to make
going to the, Mayor,
Yeah.
that's going to the policy committee this month to
Okay.
fast up that.
Thank you.
And I'm sure there will be other agenda items that may come up during this next our next meeting will be Monday, 8th of November, 2021, and that's not our usual week because of the November meeting. So everyone make sure it's in your calendar. I think it's also right after daylight savings time, so. 7th.